Today is Friday, which is at 3 o'clock. We just finished CardioAlex. So we get relieved. Actually, I'd like to thank at the beginning all the cardiologists in Egypt and Arab countries and European and America. I think this year was a marvelous conference because of the number of attendees, the number of sessions, the accreditation of the sessions, IPAC 24 and training sets 15. But this year, usually every year we have to do what's known as highlights or CardioAlex in a box. But this year we thought together the cardiology department at Alexandria University and the board to do something new. And this something new regarding the highlights. So you will see each one of us speak about her concern about preparing of the sessions, how it go the sessions, what some tricks of it, what is the advantage of doing the group. And I think you will enjoy in this video the highlights. We are trying to make it this year. I hope you enjoy this new form of highlights. Finally, I'd like to thank all the cardiology department at Alexandria University Hospital, all the cardiologists in Egypt, and all the cardiologists from all over the world, and see you in 2016. Thank you.
Ladies and gentlemen, a new highlight with Dr. Ahmed Abdel Aaty. Welcome, Dr. Ahmed.
Welcome, Shema.
You've told me before we record that there are some highlights, important highlights you've discussed this year in CardioAlex 2015. I'd like to take a quick review about it.
Good. In CardioAlex 2015, in nuclear cardiology, CT and MRI sessions, we had 4 guest speakers, Randy Thompson and Ahmed Tawakkul from USA, Joa Vitola from Brazil, and Khalid Al-Nimr from Saudi Arabia. We had 6 lectures, 6 hours, 12 presented by the foreign guests and 12 by the Egyptian group. And we had 1 hour session for challenging cases between cardiac centers with award for the best case presented by the young nuclear cardiologist. We had a very, very exciting lecture from our dear friend Dr. Ahmed Tawakkul about advanced imaging of atherosclerotic structure and biology. Exciting, really exciting insights and opportunities. And he showed us how FDG, which is known before as a metabolic tracer in PET imaging, is now can detect the areas of inflammation in atherosclerosis. We know this from 5 years ago, that it can be deposited in the areas of the vessels, denoting inflammation in this vascular territory and the vulnerable plaque. But recently, this work with PET was combined with multi-slice CT and showed us how the multi-slice CT with PET can visualize the areas of vulnerable from non-vulnerable plaques by this phenomenon. And phage density, which is a sign of inflammation or the inflammatory layer in atherosclerotic plaque. Also, what's very exciting that one of the studies showed that how the positron emission tomography by FDG can visualize areas of FDG deposition denoting inflammation of the vessels, and the vessels by multi-site CT is absolutely normal. And by follow-up of these patients over 2 years, they found that the area of FDG deposition in the vessel, which are apparently normal anatomically, they got calcification within 2 years. That means that very early by FDG deposition, you can visualize areas of inflammation of the vessels, which is the precursor for an atherosclerotic plaque or calcified plaque within 2 years. And the question is, if this has an impact of therapy? They did a very good job in studying about 4 classes of drugs in this phenomena. I will emphasize on two of them. They examined the effect of atorvastatin 10 milligram and 80 milligram on the FDG uptake in the vessels and on the outcome. And they found within 4 to 12 weeks, this FDG uptake, which was high, become decrease within 4 to 12 weeks. And this decrease in FDG uptake has very good correlation with the outcome as regards the major cardiac events, which is fantastic. Also, another drug which is a diabetologic to use in diabetes, bioglitazone, when they compared it with glimepiride, they found that bioglitazone could decrease the FDG uptake by follow-up, but glimepiride cannot do this. And the outcome in patients with bioglitazone who has uptake of FDG high got improved by this drug. What about the physiologic insights in this phenomena? They studied normal control versus patients with HIV. They found marvelous uptake of FDG in their vessels. So there is no doubt that FDG now is considered an inflammatory marker, not only a metabolic marker as we know before. What's very fascinating also in the work by Tawakkul et al. In the year 2014, that they found early deposition of FDG uptake in the aorta precedes that in the coronaries. So whenever you are looking for the coronaries, you can look for other vascular territories to detect early vascular damage before it happened in the coronaries. The most important and exciting point that they started to think outside the vessel. Atherosclerotic mechanisms may have important components that exist outside the vessel. They studied the uptake of FDG in mice after induction of MI, and they found that FDG uptake was present in the bone marrow immediately after MI, and then in the spleen, and then in the aorta. So we had two organs can visualize early FDG uptake in patients with ischemic heart disease, which is the bone marrow and the spleen. And he showed us in a paper published in 2015, Imami et al. In the JAC. If you would like to look for this study, very fascinating study. They compared the patients with acute coronary syndrome and the uptake in bone marrow to normal control, and also in the spleen. So very early, ladies and gentlemen, we can detect atherosclerosis very early by examining the deposition of FDG in the bone marrow and in the spleen before it starts to be deposited in the coronaries. A very exciting data, really. And they found that this uptake, where it is high, and by follow-up of this uptake, if they are treated the patient, you can see the improvement in the FDG uptake in these two organs and the impact in atherosclerotic plaque or atherosclerosis in general. How could we use inflammation imaging clinically today? It is very important. It already happened to detect the cases of sarcoidosis in the myocardium by deposition of FDG in these areas. Also in the device infections like infective endocarditis or infection over any procedure, you can, any device, you can, if you visualize FDG uptake on top of this prosthesis, it means there is infection here. What about the coronaries? The same happen in coronaries. Can be detected the FDG uptake before atheroma it happened. And this could be managed and examined in a very fascinating manner by the use of PET MRI or PET CT. Also, Dr. Ali Abdel Fattah from Cairo University showed us very important studies about the use of CRT to detect responders from non-responders by the phase image histogram in MAGA or the gated SPECT. And you can study the bandwidth of this histogram, and from this bandwidth you have a cutoff point. If the cutoff point exceeding so and so, the patient will not respond. Only one parameter can decide if your patient will respond to CRT or not. And she showed us a very good examples for patients where the histogram shows a very important dyssynchrony very wide base showing dysynchrony in the myocardium, and how this synchronization could be resynchronized by CRT if the bandwidth is so and so. So by this histogram, we can decide which patient will respond to CRT and which patient will not respond. Also, Dr. Ahmed Abdel Aaty showed us very fascinating results in patients with pulmonary hypertension. They showed that FDG uptake in the right ventricle could visualize patients with pulmonary hypertension who can respond to medical therapy. Whenever there is FDG uptake in the right ventricle, it means this patient can respond. And then you can follow your patient on treatment of pulmonary hypertension using whatever it is, the drug you are using, and then you follow up this patient. If you see the FDG uptake in the right ventricle is improving, this patient is improving. So the use of FDG in patients with primary pulmonary hypertension can be for diagnosis and prognosis and risk stratification and follow up, and to see who is responders and who is non-responders. Even the uptake in the right ventricle of FDG have very good correlation with the outcome of these patients and the survival. Also, Dr. João Vitola from Brazil was discussing the issue of CT angio and nuclear cardiology. Are they competitor or they complementary? There is no doubt they are complementary, they are not competitor. And whenever you are deciding to do CT angiography or myocardial perfusion study, ask yourself as a doctor what you need. What's your question? If you would like to see anatomy, okay, go ahead for CT angio. If you would like to see physiology, the ischemia present or not, and the burden of ischemia, go for nuclear cardiology. If your patient is a low probability for ischemic disease, go for multi-site CT. If it is moderate probability for ischemic, go for nuclear cardiology. So now it is black and white, there is no gray zone. You can decide to use this technique or that technique. And thank you very much.